Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Writing a review article used to be a lonely endeavour. However, in recent years, the practice of systemic reviews has changed, and the methods have become more rigorous. Reviews now offer a mechanism for mining data from multiple clinical trials to better understand patient outcomes. The manuscript we will discuss today is The Incidence of Uveitis in Patients with Axial Spondyloarthritis Treated with Biologics or Targeted Synthetics, a Systematic Review and Network Meta-Analysis. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm thrilled to be joined by the manuscript's first author, Dr. Katie Beckman. Dr. Beckman is a rheumatology registrar and clinical research fellow on a Medical Research Council-funded clinical research training fellowship. She works in the Department of Academic Rheumatology at King's College in London. She is a prolific author and has published extensively on a wide range of topics in rheumatology, including gout, medication safety, rheumatology guidelines, the impact of COVID-19 on patients with rheumatic diseases, and vaccination outcomes. Welcome to the show, Katie.
Thank you so much for having me and giving me the opportunity to discuss my work today.
So let's begin at the beginning. What inspired you to start this particular project? What question were you trying to answer?
The inspiration for this project really came from clinical experience. In our hospital, we have a virtual biologics clinic, and during these, we discuss the next treatment options for patients with inflammatory arthritis. And we were discussing a few patients who had axial spondyloarthritis with a history of uveitis, and their spinal symptoms weren't responding to a TNF monoclonal antibody. And I was just wondering what the evidence was for the next step, especially with the newly licensed JAK inhibitors and the IL-17 AF agents. When considering what the next best option was, I looked at the literature out there and I thought, actually, this needs to be updated. And that's really what inspired me to start this project.
What made you say this is better tackled through a systemic review rather than designing, say, a new clinical trial?
I think clinical trials should always be the gold standard, but when you're thinking about an event such as uveitis, which isn't that common, you would require a really large sample of patients and to have to follow them up over a long duration to be able to detect one of these events, and that's not always feasible. So a systematic review allows you to synthesize data across multiple trials. You can increase your statistical power by looking at a huge number of patients, and you can identify patterns that may not have been apparent in an individual study. And it allows you to compare across different treatment modalities, which isn't always available when you're performing clinical trials. Our research department here has really got a keen interest in performing systematic reviews, and we're constantly working on our skills at improving the way we perform these.
Tell us a bit about that. The methodology for systematic reviews has really become much more rigorous in recent years. Can you tell us a bit about the protocols for conducting systemic reviews? And in particular, why is it important to register them at inception?
For all of our systematic reviews, we register them with something called Prospero, which is an open access online database of all systematic review protocols. And when you register your protocol early, it means that it really encourages you to plan what you're going to do in your systematic review. You have to specify your research question, your methodologies and analyses in advance, which improves the overall quality of the systematic review. You can also check the database to see if there are other systematic reviews that have already been published, so you can reduce unplanned duplication. And it allows transparency. You register what you're going to do before your review begins, which means your outcomes and your analyses are unlikely to be influenced by the results. And I think that's really important right from the start.
Yeah, absolutely. So tell us about your study design in this particular study. What was your search strategy and how did you select studies to include in the analysis?
So we had two investigators who searched Medline and Embase databases from inception up until July 2023, and then again in December, just before the paper was accepted for publication. And we identified search terms that included any individual who had a diagnosis of axial spondyloarthropathy, and they had to be treated with a biologic or a targeted synthetic that was licensed or soon to be licensed. And we included any study that was identified that was a phase 2 or phase 3 randomized controlled trial in individuals with axial spondyloarthropathy, and the trials had to have a placebo comparator or another active treatment arm, and we excluded any open label studies if they didn't have a double blind period. That was the main search strategy that we performed.
And how many studies did you ultimately include? And what can you tell us about the characteristics of those patients that were in those studies?
So we identified 44 studies in total that were eligible for inclusion in our analysis. And across all these studies, which started all the way back in 2000, it started in, and then the most recent was 2023. And across all the studies, the characteristics of the individuals recruited to those studies were fairly similar in regards to their age, their baseline disease activity, their use of steroids and non-steroidal anti-inflammatory medications. But there were differences across the studies. For example, the number of males in one study was down at 43%, whilst it was up at 90% in another study, and also across the use of conventional synthetic DMARD therapy, which was at 14% in one study and all the way up to 50% of the people recruited in another study. And also we found that fairly few of the studies reported on early disease. Only about 5 of them reported a mean disease duration of less than 5 years. But importantly, there was only 28 of these 44 studies that reported on past history of uveitis. And we know that's a really strong risk factor for future episodes. And there was actually, of those 28 studies, there was a difference in the number of people who had past history of uveitis, which was down at 3% in one study, all the way up to nearly half the cohort in another study. And so there were definitely differences in the characteristics of patients between the different studies that we included in our review.
It's really fascinating, I think, partly because the field has changed so much over that basically 20-year period that you were reviewing. I'm sure medication choices and then who's enrolled in studies has changed. And obviously, I think we all recognize there's a slight change in how we are able to identify and diagnose people, with obviously diagnosing earlier and not thinking this is solely a male disease. So things have changed in those 20 years, right?
That's entirely correct. And I think that whenever we look at these systematic reviews that cross a whole 2 decades, we really have to consider how different studies are conducted now compared to how they were 20 years ago. And that's important for newly licensed drugs, which we're comparing to the TNF studies that are all the way back in 2022, 2023. Sorry, 2002, 2003.
Yeah, absolutely. So crucial question next. What was the incidence of uveitis in all these studies?
We reported a pooled incidence from the studies, which ranged from 1 to 5 episodes of uveitis per 100 patient years. So basically, if you take 100 patients and you follow them up for just 1 year, about 1 to 5 of them will have an episode of uveitis. I think the take-home message is that the rates that we were seeing were much lower in people on treatment. So they were the lowest in people receiving JAK inhibitors and the highest in people receiving etanercept. But this was far lower than the rates that we saw in the placebo group, the patients who weren't receiving treatment, which was at 10 per 100 patient years.
Wow. That's actually a big difference. So now I always like people to take us a little bit through their graphics. And you have this really nice graphic, figure 1, showing the network meta-analysis that you did. So this was the mechanism by which you compared the different treatments and their risk of uveitis. Could you describe that figure for our listeners?
Yeah, sure. So this is what we call a network plot. It really nicely demonstrates what's happening in a network meta-analysis. So you have these big circles, and the circles show the number of studies for each treatment. So as you can see, we had the highest number that included a placebo comparator. And then in regards to the treatment, the TNF monoclonal antibodies had the highest number. And the black line showed the treatment comparison, and how thick the black line is demonstrates the number of treatment comparisons. And you can see that most of our studies compared a treatment with placebo, and we just had one study that compared 2 treatments with each other, and that was a 3-arm study, the COAST-5 study that compared adalimumab with placebo and with ixekizumab.
Excellent. And so you analyze this data with some pretty complex statistics. So firstly, you looked at the probability of treatment superiority, and you used a statistical method called the SUCRA. I hope I'm saying that correctly. It's the surface under the cumulative ranking curve. Can you tell us what that is and how to interpret it?
So SUCRA is a really useful metric. in network meta-analysis. And how it works is it ranks the effectiveness of various treatments. And this is especially useful when you're comparing multiple treatment modalities. It provides a rank which is based on the estimated probability of treatment superiority from the network meta-analysis. So a sucra value of 1 would indicate that a treatment is certain to be the most effective in the network, whilst a sucra value of 0 indicates that it's certain to be the least effective. Now, in our network meta-analysis, all of our treatments rank superior to placebo, and our sucra rankings were fairly similar between the JAK inhibitors, IL-17, and the TNF monoclonal antibodies, with no real clear superiority. And I feel that really helps you understand the outputs of a network meta-analysis more easily and gives you more clinical understanding of what we're trying to demonstrate.
Yeah, and it is kind of very helpful when you're explaining that to patients when you're selecting choices in regards to treatment, for sure.
Exactly.
So you also did several analyses to correct for small effect sizes and publication bias. And in particular, you used a technique called PET piece. Now, I'm not a statistician, but I believe the PET piece is actually a combination of 2 methods, the precision effect test, or PET, and the precision effect estimate with standard error, piece. So I'm struck that despite having precision in the name, they both sound like estimates, which sounds a little imprecise. What does this all mean?
The PET piece is often used as a combination of 3 methods. So we have the Eggers funnel asymmetry test, which I think more people may be a bit more familiar with. We have the precision effect test, which is the PET, and the precision effect estimate with standard error. And so some people refer this to as the fat PET piece. Our Eggers test was significant, and that suggests that there was possible publication bias. And the way that Eggers works is it assesses the relationship between the effect size of studies and how precise they are. So a smaller, less precise study is more likely to show a large effect size due to publication biases. Smaller studies that don't find a significant result are much less likely to be published. So we then used the PET, or the precision effect test, to determine whether our effects of our study remained significant if we were to use a hypothetically infinitely larger study. But this is very strict. And so rather than presenting the pooled effects from this test, it's standard to really report the piece, which is an estimate of the pooled effect after adjusting for potential publication bias or any other bias that more likely to be present in a small study.
Oh, that's really helpful. I'm actually so glad you explained that. Critical question. What does this really mean for our patients? What truly is the risk of uveitis in patients with axial spondyloarthritis? And how should rheumatologists use the data from this study as they make decisions about treatment for their patients?
As I've said already, the incidence of uveitis for patients with axial spondyloarthritis who are on treatment is around 1 to 5 per 100 patient years. And the incidence is without a doubt higher if you're not on treatment. But I think one of the take-home messages is that we found TNF monoclonal antibodies, JAK inhibitors, and anti-IL-17 all appear to be effective. And I think that's really important. I think that takes me back right to the beginning of what would be the next choice option in someone who hadn't responded to a TNF monoclonal antibody, who had had uveitis in the past. I would have a lot more confidence in saying, well, let's go with a JAK inhibitor, let's try an IL-17. And I think that should be helpful to clinicians. And a systematic review and meta-analysis is very helpful for providing this kind of information, but we also should bear in mind that we need to then look at large observational data sets, which give us a different amount of data and really assess how patients are doing over a long period and whether these do continue to reduce the risk of uveitis.
Yeah, really, really helpful. So I really want to thank you, Katie, for taking us on that deep dive into medication management and the complexities of uveitis with a little side of statistics. I wondered if I could ask you now a couple of questions about your more personal experiences as a rheumatologist and your career journey now. So tell us, to get us started, how did you get interested in rheumatology? Were there mentors who channeled you into this career, or were you just forging your way through?
I started to develop an interest in rheumatology during medical school when I started to look after or be involved in the management of patients who had rheumatic disease. And I was really fascinated by the multi-system involvement of their condition and that you had to have an understanding of the entire human body. And a lot of these patients, especially the ones who were quite poorly, were often diagnostic conundrums. And we really struggled to work out what the underlying diagnosis was and how best to proceed. And I found that fascinating. My journey, and particularly my academic career, has been shaped by key mentors, the late Professor Justin Mason, Professor Andrew Cope, and Professor James Calloway. James and Andy were my PhD supervisors, and they've really been instrumental in guiding my career path and demonstrating approaches to conducting research, and the motivation and dedication that they demonstrate. It's really been inspiring.
Oh, great. And I'm excited that you told us about the PhD, because I'm always intrigued when people choose to go down the PhD pathway. It's long, it's arduous. It's not something that's required in the UK. It's something that many rheumatologists do choose to do. What are the pros and cons, and what do you wish you had known before you started out?
When I was doing my registrar specialty training, I started to develop this interest in the evolving treatment options that were available for patients with inflammatory arthritis. And I started to develop an interest in pharmacovigilance. Starting on a PhD really provided me with dedicated research time away from the intensely busy clinical work, which gave me an opportunity to focus on research and really hone my skills. And I think you don't get that unless you have the ability to take time away from clinical work to focus on your research. I say one of the major cons, and I'm sure this is worldwide, but definitely in the UK, is how arduous it can be to secure funding for a PhD. And it's a very competitive process, and you really have to understand the landscape of funding before you embark on that. And my advice really for anyone thinking that they may want to start a PhD around the world, but really is to find the right fit. Look for an area of research and a mentor that align with your interests and something that you enjoy, and gain some research experience before deciding on a PhD, and find what type of research environment suits you and whether this is something you want to dedicate your time to for the next 3-4 years, because that's how long it can take.
Yeah. It's sometimes even longer, right?
Oh, yes, definitely.
So tell us a little bit about the Medical Research Council Fellowship, which I think is how you were able to secure funding for your PhD training. What is it? How does one apply for one? And how has it impacted your career?
The Medical Research Council is a prominent funding agency in the UK, and among other things, they fund pre-doctoral fellowships. So that's for any clinician or healthcare professional that wants to take time out from clinical training to embark on a PhD. And the MRC, they'll fund your salary and any additional project costs. And as I've already said, applying for one of these fellowships is very competitive, and the application process and interview process are arduous. And I still remember my PhD fellowship interviews being one of the most terrifying situations I've ever been in, being interviewed by 20 to 30 people around one table. It's scarred me, really. But securing funding has been instrumental in my academic career because, as I said, it's allowed me to carry out my PhD using dedicated research time. And applying for the fellowship allowed me to develop my abilities in writing a grant, developing a research idea that was feasible, novel, and working out how you actually go about writing a grant, which has been very helpful for my academic career up until date. And I'm currently continuing in the academic field. I'm about to start my NIHR clinical fellowship. So really, I've now down the academic path. And I think without my PhD and without funding from the MRC, I wouldn't have been able to do this.
That's great insight and advice. Now, you have multiple manuscripts to your name, and unlike many of us who spent the last 4 years surviving COVID-19 and then trying to regroup and recover lost time, you seem to have only gained momentum during the COVID-19 years. Tell us about your writing practice. Are you an early bird? Do you like to write late into the night? How do you get it done?
I should first say I was very fortunate that I had completed my PhD prior to the onset of the pandemic. And I know lots of my colleagues struggled completing work when the pandemic hit. And in my department, we were very involved in a lot of the COVID-19 treatment trials and subsequently the vaccination trials. And this provided me an opportunity to engage in research projects that were relevant to the pandemic, such as understanding the risk of COVID in our patient population and evaluating vaccine efficacy. But in regards to writing, I feel this is a part of research that I really do enjoy. Putting together a manuscript is one of my favorite tasks. I feel the more you write, the better you get. I am an early bird, but I also have a horribly long commute on the London Tube, and I'm often found writing deep underground during a tube journey.
So the cell phone can't get at you there, right?
You've got some peace, as it would be.
Okay, well, so that's the answer. We should all go to the London Underground. Do you ever get writer's block? Do you have any tips for getting through that?
I do get writer's block. I think most of us do. I work with a great team and I've always got the ability to bounce ideas off someone. But one of my areas I've really learned is not to agonize over a sentence for hours, because I used to do that. And then that sentence would get cut when another author reviewed the paper, and I would find that gut-wrenching. So I really have tried to get over that agonizing. But yeah, that would be, my tip would be to try and bounce ideas off someone if you get stuck with writer's block.
Yeah, good advice. Make it a communal activity, not so lonesome. So what's next for you in your career, Katie?
So I've always had this keen interest in pharmacovigilance, and I'm going to spend more time focusing on that. And I plan to analyze large observational data sets, often national data sets in the UK, trying to answer some of the more intricate questions regarding safety of the medications that we use for individuals with inflammatory arthritis. Coming to the end of my specialist rheumatology training, where I need to start thinking about consultant jobs and academic pathways. And so that's kind of where I am at the moment. And I hope that I can continue in the academic work that I really enjoy.
Excellent. I will wish you a kinder interview for consultant posts than it sounds like your PhD interview was.
Yes, that'd be great.
Oh, Katie, thank you for joining us today and sharing your experience as a rheumatologist and as a researcher. It's really been an absolute pleasure talking to you.
Oh, yeah. Thank you so much for inviting me, and I've really enjoyed myself. Thank you.
My thanks today also go to all authors. Writing is a labor of love, and medical authors have to be incredibly resilient. They must overcome not only the challenges of conducting the research, but also the feedback from reviewers, in particular reviewer 2. Thank you for persevering and writing a lot so that we can all learn and put research into practice for our patients. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRheum on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.